thank you so much for coming, everyone, to this EU Joint Action on AMR and Healthcare-Associated Infections meeting. This is probably our last Work Package 9 meeting before we take a little bit of a break for the summer holidays. Not that we'll take a break from the work that we're doing on Work Package 9, but we'll probably take a break from some of the webinars. This webinar, of course, is on the a proposed Nordic revenue guarantee for paediatric phenoxymethylpenicillin. And we're going to start with a brief presentation from Lina Pasterak, who comes from the Swedish Ministry of Health and Social Affairs. Over to you, Lina.
Good. Thank you for inviting me, and I wish you a very productive and good meeting. I work at the Ministry of Health and Social Affairs with AMR and national vaccine programs. And I wanted to start off by saying that access to antibiotics has been a priority for the government for quite some time, but accelerated in the recent years. So in 2023, we had the EU presidency, and access was one of the issues that we prioritized, and there were expert conferences, there were reports, ministerial meetings, and so on. The outcome was really a council recommendation on stepping up EU actions. And I think many of you are familiar with the graphics on the right-hand side showing the end-to-end perspective that we always have to bear in mind, all from discovery to regulatory work and access and innovation. And following on the EU presidency, in 2024, we had the presidency of the Nordic Council of Ministers, and there was also a very important high-level meeting in the General Assembly on AMR. And I wanted to kind of show you through this timeline what we did. So in January of that year, we got a report from the Public Health Agency of Sweden on access to antibiotics in the Nordic region, the challenges, the possible joint work. And we took that report further to the Ombudsman Committee, which is a function where the representatives from ministries, and they discussed the report and prepared for the ministerial discussion that the Nordic Health and Social Ministers had in May in 2024, which was very interesting. And the result of that was that they wanted to continue the work and strengthen the work on access based on different proposals in this report I referred to. But they also wanted to see if it was possible to expand the Swedish so-called Netflix, the revenue guarantee model that we had experience from, to see if that could be expanded to other countries in the Nordic region. So to look into that, we established an ad hoc working group, which is led by the Public Health Agency of Sweden, and they actually continue their work, and they have delivered different reports, and they got new mandates and so on, but it's still up and running. And in November in 2024, there was a Nordic conference in Uppsala on how to strengthen access in the Nordic region. And also we adopted a declaration from the ministerial levels, both agriculture, environment, and health. So One Health declaration, where I believe that the access issues were really strengthened in relation to previous declarations we had in the Nordic Council. In June 2025, the Nordic Council of Ministers Ombudsman Committee decided to finance and fund a Swedish project which is headed by the Swedish Medical Agency, and it's really to continue focusing on coordination in the Nordic regions between different streams needed to ensure access. So the results of the conference in Uppsala, so to say. And that project is called NORA. And last December, there was a decision on a multi-annual AMR program in the Nordic Council, which is financed by 3 sectors. I included a small illustration here on the right-hand side, showing that a lot in the coming years will be kind of coordinated by this program. It has a secretariat function at the Public Health Agency of Sweden, and projects such as the NORA or the ad hoc group, they are not yet in this program, but I think there is important to link it to each other so we're aware of what's going on where. And again, the ad hoc working group continues to work on both how to have joint procurements in the Nordic region, but also a possible model pilot. Then I wanted to say something about a recently adopted strategy for antimicrobial resistance from November last year. It's a strategy where it has a 10-year perspective. And we have 17 overall targets that are mostly quantified to show where we want to be in 2035. And it's a national strategy, but it also includes a goal on global action or international cooperation. So these 17 targets, they are divided and clustered around, for example, Sweden's objectives for the level of AMR that we are heading for, or maintaining the level of AMR, the objectives for antibiotic use, for prevention, for healthcare associated infections where we want them to be reduced by 1/3 until 2035, and the objectives for access to antibiotics. So here the targets are really to ensure to ensure that shortages of antibiotics and other antimicrobials are to be reduced compared to the baseline year 2025, and that the best conceivable treatment for the WHO's pathogen list should be supplied on the Swedish market and accessible. So there's really the goals, the objectives. And in the strategy, there is a target area 9, where we talk about what should be done, what do we need to do in order to ensure reliable access and diagnostic tests. And here, of course, the government is trying to give different assignments or strengthen agencies or support projects to be able to move in that direction. And some of the work that we've done, I've listed here. We have given TLV a government assignment to analyze the pricing system and the effects of access to antibiotics when we talk about outpatient sales. The government has purchased through APL a factory with the production capacity for antibiotics, penicillin primarily, based in Strängnäs, which is a new thing for us. We, of course, work a lot in the EU, not least through the work related to the pharma legislation, which is to be adopted soon, and indeed the Nordic cooperation. So the Swedish experience when we talk about different reimbursement models is really work that has been ongoing at the Public Health Agency of Sweden for many years. They've developed reports and suggestions for two different work streams. One is on new antibiotics, which is an ongoing project or model. We call it, or it's called the Netflix model. It's a model for new antibiotics with no generic competition and for products that are used only in inpatient care, where companies get a guaranteed revenue, which is linked from sales. The regions, hospitals in Sweden pay for their own purchase and use, but the state kind of pays for the possible risk that the sales are not enough, that the market will not be enough to solve this problem. And currently, this model includes 4 products, and there will be hopefully a new assignments for 27 and 26. So here you see a graph of how, I'm sure you've seen it before, of how the model is composed. The other suggestion we received in 2023 from the Public Health Agency of Sweden was on old antibiotics, where they had a preliminary study of how we could have a buffer stock of prioritized off-patent antibiotics, the older ones that we are so reliant on in the Nordic context. And they provided a list of older medically important antibiotics with a risk of being insufficient, that are needed in first-line treatment and are not interchangeable. And they suggested a model for procuring availability to a central buffer stock of older antibiotics, and where we would then compensate the pharmaceutical companies to incentivize them and keep their products on the market. And the result of the report was they suggested the government to go ahead with a pilot study, finance it, and to test and implement a model that links this to Nordic cooperation. And I think this is what as I understand, I don't follow it that closely. I think this is what is now trying to be done to link this older antibiotics work in the Nordic context to also the Swedish market. So what I wanted to emphasize today was really that access is a key priority for our Minister Forssmed and the whole Swedish government. And they are very interested in creating a larger and more attractive market in the Nordic region or even beyond, and to keep the momentum where we implement the ministerial declaration through various projects and programs that I tried to show you, the One Health AMR program and the NORA and the ad hoc working group and so on. And I think that the NORA and the ad hoc working groups have different perspectives, but needs to be linked to each other. And that is what I wanted to say. And of course, I'm open to take any questions.
Great. Thanks so much, Lena. Any questions for Lena? I guess the obvious question, Lena, I don't know if you appreciate this question, is what do you expect for Strongness?
For?
Strongness, the factory that you purchased. How do you see that fitting in?
Well, we think that it fits into how we look at, civil preparedness and all that. And it's an ongoing work. I visited it myself 3 weeks ago. I think it's very interesting what they managed to do. But it's new, so it will take some time until we figure out what the capacity is, what the needs are, and so on. But we say it's part of a verktygslåda. I don't know how to put that in English. Toolkit. It's part of the, yeah.
Excellent.
Of course, it's definitely not a factory. I mean, we are still dependent on the APIs from other countries, but production can be made there.
Excellent. We're a little bit of a shy group, Lena, so we don't get a lot of questions. Sorry. So,
that's all right. I hope I managed to anyway say that your work is important and that access is really a top priority for the Swedish government in all different aspects. Also now when we prepare for global meetings like in Abuja and so on, access not only in our own region, but access to patients worldwide is very important to limit mortality related to AMR.
Thank you so much for your time. We really appreciate it.
Thank you. Bye-bye.
Bye. So now it's my pleasure to introduce Jan Kenneth Poulsen from the Danish Medicines Agency, and he's going to get into the meat of the matter and tell you all about the proposed model. Jan, over to you.
Thank you, Christine, and thank you for inviting me. I also have a presentation. I will try to make it visible for you also. Yes, can you see it now?
Perfectly, thank you.
And in the right mode? Presentation
absolutely, mode? Absolutely perfect.
Perfect. Yes, I'm going to tell you a bit about this joint Nordic cooperation with this Nordic revenue guarantee model, as Lena just mentioned just before. And I have to apologize for my a little bit rusty voice. I just still have a bit leftovers from a flu last week, but I hope you can manage that. Just a little bit of background. As I think you probably are aware, the Nordic countries have a strong tradition in antibiotic stewardship. According to the ECDC, the Nordic countries have the highest proportion of narrow spectrum consumption in Europe, as you can see from this table, which shows that the measure the ratio of broad spectrum antibiotics consumption to narrow spectrum consumption. But it's a very this situation in the Nordic countries are very unique. However, the Nordic countries are also very small compared to many other countries, and fragmented And combined with this a declining global market for narrow spectrum antibiotics, this puts the Nordic countries in a sensitive situation, including the risk of shortages and withdrawals. So, because of that, and against this background, a joint Nordic clarification work has been initiated, as you just heard, with proposal for two initiatives for both the primary and secondary care, respectively, and which has resulted in the mandate from the Nordic Council of Ministers last year, as you can see on the slide. First, to develop a revenue guarantee model for selected critical narrow spectrum antibiotics in the primary care and private sector in the Nordic markets, to ensure that availability is going to be better by making this attractive for companies to remain in the markets. This is what we call Model 1. And also, we had a mandate to expand the existing Danish, Icelandic, and Norwegian joint procurement of hospital antibiotics with Finland and Sweden. This is called Model 2, but what I'm going to focus is only on Model 1 in this presentation. And in our work, we should look at all regulatory, pharmaceutical, and mercantile challenges, and come with proposals for how to deal with those issues in each country. We had a deadline for this work started this year. Started in January this year, and after we finalized our report at that time, and now we're waiting for a political approval by the Nordic Council of Ministers, and also an indication from each country to what extent they are going to participate. There has been held a meeting in March in the Council of Ministers, but because in Denmark 2 months ago we had the general election, we had no governments, so the meeting was postponed. Actually, after 2 months, we still have no government in Denmark, so we still need a bit behind with this formal approval from the Nordic Council of Ministers. But now I will go a bit more details in this revenue guarantee model. And I think, first of all, there's no doubt that the Nordic markets for these narrow spectrum antibiotics will appear most attractive for the industry, and thereby also result in the best security of supply if the markets can be combined and thereby considered as one common Nordic market with 28 million people. But first of all, this will require significant changes in several areas: the pricing mechanisms, procurement, distribution, storage, and other national processes in each country. So this is a huge job if you have to make all this together. And secondly, there's also the fact that no one has yet implemented such a model in the primary sector. So we are on certain grounds. So therefore, the working group proposed to start with a pilot model. And the pilot model has some common Nordic principles for all countries, but all these issues about pricing, procurement, and so on are going to be applied as normal in each country. And each country should negotiate nationally adapted service contracts with each marketing authority holder for one specific drug. Come back to that. And if this pilots ends in good results, and that is when we are eliminating our shortages or reducing shortages of products, then we can go further to a more a bigger model with maybe more products and maybe a more joint view at Nordic markets. But for now, we start with this this pilot model, which will prove us as a proof of concept for maybe a more permanent model. And the product that we chose for the product is, as Tristan also mentioned, phenoxymethylpenicillin, 50 milligram per milliliter in an oral suspension for products primarily for neonates and toddlers, which is of course a very vulnerable population. It's a very commonly prescribed antibiotics in all the countries. So that is why we chose it. And when we chose the product, there has been close periods of significant shortage problems in several of the countries. And now here, a year more later, the situation for this product looks better, but until something else is decided, we will continue to have this product for the pilot. And in our countries, there are all 4 companies holding a marketing authorization. In some countries, only 1. In others, up to 3 companies. And this is a model which is going to be for the pilot be implemented in each country if they want to participate. However, for Iceland, because of the small market in Iceland, the model, the solution for Iceland would be combined with the Danish model. And the model is strongly inspired by a similar Swedish model for new hospital antibiotics. There are 2 major components in the model. First, there's this guaranteed annual revenue, which in the model is set to 850,000 Swedish crowns. And then on top of that, there's an annual fixed participation revenue of 400,000 Swedish crowns. Why these actual numbers together, 1.5 million crowns, meet the amount of annual revenue assessed to be sufficient to maintain a marketing authorization for the medicine in the country. This was founding conducted by TLV in Sweden. And we are carrying out this result. So in order to stay in the market, the companies need to have a revenue above 1.25 in practice. And of course, this revenue guarantee means that the public sector undertakes to pay the difference between the guarantee amount and the actual annual sales, if sales are lower than this guarantee. If sales are higher, of course, there's no compensation in addition to the fixed payment. So this is very simple. The model is going to be implemented in each country. A central element of the model is that we have service contracts, which we in the model calls authorization schemes, that must be concluded between a national authority in each country and each marketing authorization holder for this specific product. We have suggested this instead of competitive tender, because this allows all companies that meet some basic requirements to be a part of the model. And thereby there's a rationale to allow new and serious entrance to the market. On the other side, the requirements in the contracts of the scheme are very stringent, so that non-serious actors will be dissuaded from joining. And we want the contract period for this pilot to be at least 2 years in order to gather enough experience for an evaluation. On top of that, we have to have about half a year from the announcement of the model to start the actual implementation. And the service contracts contains, among other things, a number of requirements that the company must meet, as listed here on the slide. First of all, they have to have an active marketing authorization for the product. And dot number 2 is the general rules have to ensure that the orders for the products are always fully supplied up to a maximum order quantity that arrows the total annual demand for the product for the last 3 years, resulting in no product shortages. This is the general rule. If the countries should the countries should be able to determine their own maximum order quantities. For instance, if countries with multiple marketing authorization holders may not need to complete redundancy amongst suppliers, and they have only high requirements that maybe have the result that they have to destroy products afterwards, and so on. So it is up to the country itself what this maximum quantity should be, and as it depends, I think, of how many suppliers the product you have in the market, but that needs to be a maximum order they have to fulfill. And very important is also number 3, that in this scheme there are no stockpiling requirements at all. They just have to when it's in the contract, say we can fulfill this contract. That is enough. That's believe on their words. And then there are some points on to avoid gaming, especially for Sweden and Denmark, because our pricing systems in Sweden, the company have to have won at least 1 or 2 of the monthly competitions within a year. In Denmark, they have to have held what called the A price, which is the cheapest price in the market, for at least 6 pricing periods each year of the contract. In Denmark, this periods are 2 weeks at a time. And of course, there are also some obligation on the other side of the table. The public sector contract holder, which is not actually specifically defined who is going to be in this country. It's up to the country itself, which authority has this job. But they have to every year to validate and pay the difference between the guaranteed annual revenue and the actual sales, and maybe have to deduct for contract non-compliance. I'll come back to that just in a few seconds, and also pay this annual fixed participation revenue. And of course, have to secure that all this information from companies are kept confidential, and also have to make some audits if that's necessary. Then we have added some rules if we see non-compliance. if and this is mainly because of to discourage gaming, particularly by new entrants. So if there are shortages for more than 2 weeks in a row, or more than 4 weeks in a total year, the income guarantee will be cancelled totally for that year. And for each week of shortages, the fixed amount are reduced by 10%. And in case of more than 4 weeks in total, the fixed amount will be cancelled completely for that year. And in our work, we also looked at if the pilot and potentially a more permanent model will require any legal or regulatory changes. And luckily, the answer for Denmark, Iceland, Norway, and Sweden were that there are no legal barriers, except some minor details in how we finance this in Denmark or in our state budget. So, but it's there are details. The situation in Finland is different. In Finland, there are lack of a legal basis and a regulatory framework and a structure to establish this service. But also in Finland, they have this system of obligatory stockpiling of medicines. So, and this is compared to many other companies, a very strict level of stockpiling. So because of that, the revenue model is considered to be unlikely to provide any value added in Finland. So this would not be a tool that would be useful in Finland. So yeah. And on my last slide, we also looked at what about the rules of state aid. Are there any conflicting issues here? As stated, I just wrote the definition. Any type of advantage provided by national public authorities to specific companies on a selective basis and is regulated by specific conditions. And both the pilots and the potential long-term model must be considered as state aid, since there are financial assistance from this public body to selective companies. So there's no doubt this is state aid. But also, as I write in document number 3, this is considered as what they call service of general economic interests. Because that there are more lenient rules regarding to how to which rules we're going to use about the state aid. And for the pilots, the rules we use is called the de minimis regulation rules, which allows member states to grant small amounts of aid, and the size of this amount is 750,000 euros per company over a 3 years period. So this is way over the amounts in our model. So there's no problem for the pilot. There could be some problem for the long-term projects that we have to come along. And it's among all, it depends on whether we choose this for long-term model of fertilization schemes, or we will choose at the tendering process. The rules for tendering process are much more easier regarding to state aids, but we have to look into that, and we also have to have a dialogue with the Commission on that one. So, but for the pilots, there are no issues which we can kind of overcome regarding to state aid. So I think this was my last slide. Yeah.
Wonderful. Thank you so much, Jan. I think I'll just do my presentation very quickly, and then we'll open it up to discussion. Let's see here. You can see the slides okay?
Yeah.
Yeah, perfect. Okay. So just to, I mean, Jan's basically described most of the details. So I just wanted to come back to some of the considerations and complexities. So why a revenue guarantee? Why are we talking about this? Well, the theory is that a revenue guarantee which pays for access but not for consumption can be useful to bring a product up to a certain profitable threshold. So this is for particularly important antibiotics with very small markets. It's the intent is that the revenue guarantee will make the market more attractive by paying for the service of securing availability. We saw from both Lina and Jan that it worked for Sweden. Sweden, through their revenue guarantee for new hospital antibiotics, had by far some of the highest access to these new antibiotics in the world, actually, after they implemented it. So you could think that there's alternatives. Countries could just bulk purchase large stocks and, go through these stocks as they need to. But this actually would create a more unpredictable market for industry because you'd have large purchases in unknown periods. And so therefore they could discontinue the line production or not plan the batch production for that product, both for API, active pharmaceutical ingredients, as well as finished product. So the revenue guarantee gives a predictability that's desirable. Also, there's a lot of different supply chain actors. So raising the unit price might not actually benefit those companies that actually produce both the API, the active pharmaceutical ingredient, and the finished product. So I can take my own country, Norway, as an example. We have private wholesalers. They are the companies that service the community pharmacies. So they have negotiating power with the marketing authorization holders, and take a margin, a percentage of the price that's paid by the customer when they get an antibiotic. So we have to be careful about which actors in the actual supply chain are we trying to stimulate here? Which of those actors do we think, we want to make sure they have additional revenues and have control to secure additional access? And this is why a revenue guarantee, which would be given actually to the marketing authorization holder, is we think stimulating the right point. But I want to emphasize that this is an exceptional reimbursement method. This is not meant to be the norm. It's not considered appropriate for most antibiotics. And quite honestly, one of the reasons why we're doing this is we're doing it because we don't know the answer to this question. To our knowledge, no one has implemented a revenue guarantee for a generic medicine. And so will a revenue guarantee ensure either predictable supply, meaning eliminate shortages, or alternatively secure access to a primary care generic antibiotic, especially critical in the Nordic countries? So we see this pilot, if it goes forward, as basically a test of this question, which we quite honestly don't know the answer to yet. And as Jan said, the ideal model would be to have one market. If we take the 5 Nordic countries together, we are actually 26 million people, which suddenly brings the Nordic countries up as an aggregate into the 6th largest European market, in between Poland and Romania. So it would substantially help us to secure access to antibiotics and other medicines. And we could use the bargaining power of the entire Nordic market on a single meat tender. Meat means most economically advantageous tender. And you might have seen this come through in the recent approval of the Critical Medicines Act. So there's a lot of potential that if we can act as one market, we could have better access, and we could favor other pricing points than just price. We could at environment, we could look at, of course, security of supply and others. And it could be more attractive, we'd be more attractive from a company perspective, and ideally attracting 3 to 5 manufacturers. So when we look at creating a more resilient supply chain, it's really the actual producers that we're interested in having resilient supply from, meaning active pharmaceutical ingredient producers or finished product producers. Having multiple marketing authorization holders that are supplying the same product that's produced from the same company does not actually give a resilient supply. It just gives multiple marketing authorization holders. So, there's a lot of opportunity here if we had one market. But in the short term, like I said, we don't know the answer to the question, and a full-scale Nordic implementation could be disruptive. Because we do have different marketing authorization holders. We have so we don't want to lose access. We don't want to. We want to ensure that this is a very important product in our countries and that we maintain access. But we don't necessarily all want the same products. So I think that's important to recognize as well, because even as much as the Nordic countries are alike, we still don't have exactly the same desires. And of course, we want to do no harm and test through the proof of concept. So what we decided to do was to do a unified unified approach, or this is what we've suggested. We don't know if the countries will actually adopt this, where each country tenders a revenue guarantee to the existing marketing authorization holder with similar terms. So basically, the 5 countries are acting, or the 4 countries, because Finland has said that this doesn't work for them, which is fair enough. But if the 4 countries move in the same direction with similar terms, is actually the desire here. And of course, it's a service contract where we're paying for reliable supply. We're not paying for product. We want to avoid the legal, regulatory, operational disruptions or changes. So that's why the evidence that Jan presented is very important, because in order to test this question, we don't want to have to change laws or regulations. So it's very good that the 4 countries actually don't have like legal barriers. And then if the revenue guarantee is actually successful, then we can revisit. Maybe we do wish to act as a single Nordic market, or maybe not. It's we have to see what the outcomes are. So what about gaming? Jan talked about this as well. I mean, you could see this theoretically, that many marketing authorization holders could enter the Nordic country markets, collect the revenue guarantee, and really have minimal supply demand. So this is something that we want to avoid. There's really kind of probably a sweet spot about how many marketing authorization holders you actually want. We don't need probably 10 marketing authorization holders for pediatric phenoxymethylpenicillin. We want to have a resilient supply, so we need a few vendors that we can rely upon, but we don't want to have excess companies that really are non-serious actors. So as Jan said, we put some requirements in there: active marketing authorization, participation in the product of the week and the month competitions. So Denmark selects the product basis, the product of the week basis. So that is the preferred product to be dispensed in the pharmacies. Sweden has a similar process for the month. So we want to make sure that these systems that have worked well in Denmark and Sweden continue. So you could think that a company could theoretically game the system by putting in a high price for these product of the week and product of the month competitions, and thus never be selected, but then collect on the revenue guarantee. And so therefore we put in these requirements that they have to participate in these competitions. They have to win the competitions a number of times during the year. So we've also, as Jan went through, we put some big penalties in place, not penalties that the company would have to pay us, but penalties that the company would lose the revenue guarantee. So in order to discourage non-serious actors. There's also, of course, a possibility that you could have a competitive selection process with set entry points, so that potentially you just tender this out, once every 3 years or something. And if the company doesn't come in, it doesn't come in the first application period, they have to wait a set amount of time to come into the next one. But that was considered undesirable by some countries, because there is a desire to allow marketing authorization holders to come into the market. We don't want to close the market necessarily. But we also don't want to encourage wastage or supply disruptions elsewhere. We don't want a Nordic revenue guarantee with high requirements for supply to mean that other European countries or other countries elsewhere don't have access to the product. So this is a big concern. So we tried to make it flexible, saying no stockpile requirements. So giving the companies flexibilities to manage their stock and circulate their stock throughout their markets. To see, this is really a learning opportunity for us. We're unsure. But then also to get this annual reporting, including the numbers of packages destroyed. So if we do see a lot of packaging or a lot of product being destroyed, then I think we have to revisit this. But then, of course, it comes down to in the end, how do we know if this worked? How do we know if this was successful? Since after COVID-19, when there was a surge of pediatric infections in 2023, really there's been very few shortages of phenoxymethylpenicillin mixture. So since we've had no shortages basically in 2024, 2025. How do we know if this actually does work or has a difference? We didn't need to do this. So ideally, in order to do that, you would want to look at a longer period, a 2 or 3 year period, but maybe that's too long. There's question about, how long do you actually want to have a pilot? We need to assess, of course, shortages across all 5 countries or all 4 countries. If Sweden's always getting product, but Iceland isn't, then it's not working as we envision. We want to look at shortages across other countries to find out if the stock or if the availability requirements are actually influencing other countries so that they are not getting the supply. Look at the destruction data. We want to talk to the companies and also, of course, see if the marketing authorization holder landscape has changed in any of the 5 countries during the pilot. But maybe you're sitting back and thinking, wow, the Critical Medicines Act, this was just passed last week, right? So won't this solve this? Why should we do this? So a couple of points here that phenoxymethylpenicillin has had 2 EU-based active pharmaceutical ingredient producers and at least 2 finished product producers for decades. So we have a company in Austria and we have a company in Slovakia. So these are products that are made in the EU. So that's great. So the Critical Medicines Act, of course, is trying to get more European production. The other question is, older is phenoxymethylpenicillin? It is included in the critical medicines list, but is it really a medicine of common interest? The critical medicines list doesn't include formulations. One of the first focus points of the Critical Medicines Act actually be to focus on this very small market of phenoxymethylpenicillin, and particularly the pediatric strengths and formulations. We'd probably doubt that. And then, of course, primary care products, the Critical Medicine Act only applies to those products that are actually publicly procured. But in many countries, these phenoxymethylpenicillin is, of course, provided in community pharmacies through the private sector and not tendered. So this is the question that we hope that the Nordic countries will decide to go forward and test. Will a revenue guarantee ensure predictable supply and eliminate shortages to this important product? So we do not know the answer, but we hope to find out, and we think that this could be a part of it. Thank you very much.